on the short side, so I'm gonna bring this down. Can you actually see me, or did you just see the podium? Okay, thank you for that kind introduction. Thank you for inviting me to speak here. So do I go forward? How do I use this thing? Push the center button? I'm gonna try. Here we go. Okay, this is my disclosure. I'm gonna start talking today mostly on the bottom part. So even though I do motility from top to bottom, but we're going to focus on the bottom. There's a lot of topic to actually cover. So if you run out of time, feel free to grab me afterwards for any questions. So I'm going to first talk about overview on anorectal manometry. It is used to measure anal sphincter and rectal pressure and assess their function. And the indication for anorectal manometry is chronic constipation when they're especially refractory to medications. Fecal incontinence is also used for biofeedback therapy to treat these conditions. It's also very useful, I don't know if people know, it's actually to assess patient pre and post interventional surgery. So if you have a patient who's thinking about reconnecting the colon or removing their whole colon, you want to make sure that anorectal function is working, because if it's not, you can reconnect and they will still have issue with defecation process or with fecal incontinence. So the catheter comes in 3 types. There's a water perfused catheter. That's originally what it comes with. Now we mostly use solid state catheter, so you don't have to actually calibrate as much. And there's also the 3D catheter, which you actually can see, given that the anal structure is a circle, you really want to see it really more of a 3-dimensional kind of face. Protocol and patient preparation. So the way we have patients, generally we have them do a enema prior before they come for the procedure, so the rectal vault is clean, and then we will insert the catheter through the anal canal into the rectum. A patient usually is laid in the left decubitus position. Now there has been some paper and some debate, is that that's not the most right. When you go defecate in the toilet, you don't go on the left decubitus position. However, because the way the catheter position, if you put them on a commode, sometimes it will fall out. Although there are paper depicting perhaps doing in a sitting position is more natural, more physiological. But currently our center is using the standard left decubitus positions. So I'll go over a little bit of what we do in anorectal manometry, kind of the analysis and interpretation. What we're looking for during the anorectal manometry is looking at the resting anal pressure and the anal canal length. We then do the squeeze study. We then assess the different reflex activity. This includes the rectal anal contractile reflex and the rare, the rectal anal inhibitory reflex. Then we do sensation study, and then we have them simulate defecations where they actually do that bear down maneuvers. And then we check for rectal compliance. Rectal balloon expulsion test is not part of our arm, but it can be done separately, but we do it as a protocol in our center altogether. I just want to briefly to talk about anorectal manometry and anesthesia, because we do get pediatric patient, and as you can imagine, for kids, shoving something up from behind is not something that would be very happy. And a lot of them do undergo anesthesia doing actually anorectal manometry. So rectal anal rare can be elicited even when is performed under general anesthesia. So that's actually part most important for these pediatric patients when you want to rule out Hirschsprung's disease. Glycopyrrolate and anticholinergic appears to inhibit rare. So these are the things you don't want to use if you're going to do anorectal manometry under anesthesia. And propofol can lower resting anal pressure. Okay, so we start out by measuring what the resting pressure is. This resting pressure generally is constituted by the majority internal anal sphincter, or the IAS. You can see 50% of the anal resting tone is from the internal anal sphincter muscles. About 30% is from the external anal sphincter muscle, and then 15% is from the hemorrhoidal plexus. I want to emphasize a little bit on here. I think people don't realize a lot of patients come and say, I want my hemorrhoid removed. But I often remind patients, unless you really need the hemorrhoid removed for actually a good reason, that actually hemorrhoidal plexus, especially the internal hemorrhoids, is very important in kind of contribute to that resting tone. So you don't want to end up with complication of fecal incontinence and other issues. So I think we have to really actually educate patients about this. Now, during the study, we really look for the competency of the anal sphincter. So if the resting anal pressure is dependent on sex and age, so they're generally lower in women and decreases with age. When you have a low resting pressure or asymmetry of the actual muscle, patient can present with fecal incontinence. This may be due to both internal or external anal sphincter injury or patchless anal canal. Now, high anal resting pressure may suggest smooth or striated muscle spasm. So patient with anal fissure or anal pain, you might see that. And that's another pearl. If on your physical exam, you see patient come in with anal fissure, don't send them for anal rectal manometry because you're going to read high pressure. It's best to actually treat that anal fissure first and until that healed, then put them through the anal rectal manometry. You get much more accurate testing. Next thing that we look for is squeeze study. This is testing for their muscles contraction strength. So we have the patient squeeze as long as possible for 30 seconds, 1 minute rest in between, and then repeat. The rectal pressure should not increase because we just want them to contract the sphincter muscle, not the abdominal muscle or anything else. Now, sometimes you see this low squeeze pressure, commonly it's actually patient non-compliance. Again, these are muscle back there, right? You don't, the patient don't see it. Sometimes they don't know what to squeeze. That's part of the problem. They have no idea what they're squeezing. Or you can see weakness from the external anal sphincter muscle due to muscle or nerve injury. The weak squeeze pressure is very low sensitivity for identifying sphincter injury or a patulous anal canal, but does have high specificity in detecting external anal sphincter or puborectal muscle injury. You can see early fatigue, so if they cannot hold the squeeze pressure for a certain duration, that may be suggesting a possible either pudendal nerve issue, and patient may present more with liquid incontinence. If there's asymmetry due to surgery or defect, then you will also see that, especially mostly noted here, you can see the two picture on the one hand, the healthy subject, you have that nice squeeze, circumferential altogether, and patient with fecal incontinence who lose that squeeze, and you can see very nicely that that squeeze is not there, and then the anal canal essentially like a tube. High squeeze pressure sometimes can be associated with male chronic pelvic pain. Okay, I want to talk about rectal anal reflex activity a little bit. There's two. One is a rectal anal contractile reflex, which is a compensatory mechanism to really maintain your positive anal pressure when you have a sudden increase in intra-abdominal pressure. So if we cough, if we sneeze, we blow into a balloon, you don't want to, dirty yourself, because thank goodness, our reflexes where the anal sphincter muscle will actually increases, and it's very essential in preserving continence. So if the patient have a low squeeze pressure, but they have a normal cough reflex, it generally means there's some kind of impaired volitional control of the external anal sphincter muscle, or maybe a damage to central motor pathway above the sacral segment of the spinal cord. But if they have a low squeeze pressure and their cough reflex, well, for us, we actually have them blown to balloon. If that external sphincter doesn't go up naturally, then it's probably some kind of defect in the sacral reflex arch, which include the pudendal nerve and the sacral root. The rectal anal inhibitory reflex, again, very familiar in the pediatric world because that's what they look for Hirschsprung's, or to really rule out Hirschsprung's disease. So you should see, so as the rectum being distended, there's a natural reflex for the anal sphincter to relax, and that's the internal anal sphincter. And you have volitional control to say, no, this is not time for the place, even though my rectum is full, but I need to make sure I find the right place to then let it come out. So if that's present, you have a functioning myenteric plexus. It's unlikely to have Hirschsprung's disease. The loss or the absence of rare generally can suggest dysganglionosis, some kind of postcircular myotomy, low anterior resection, megarectum, or tonically contracted external anal sphincter. Rectal compliance. So in motility, it's all about muscle tone and about propulsive force. So the rectum is a muscular structure, and it has its tone and stretchability. So this is measured in milliliter over millimeter of mercury, calculated as a slope. This is physics, going back to physics day, change in volume over change in pressure. It is not a linear curve, so we have to understand that. The balloon distension generally initially increase the rectal pressure, followed by a slow pressure decline to steady state, what we call accommodation. We can see that actually in the stomach as well. Barostat is a gold standard. I don't think too many people practice actually rectal barostat. We do stomach barostat in our center. Satish Rao has described, I think he does rectal barostat in his center. You can see reduction in rectal compliance, usually result in rectal urgency or frequent defecation. These are commonly associated with either IBS diarrhea, inflammatory bowel disease, ischemic disease of the rectum, radiation. Just imagine, right? If you have some kind of injury to the muscle and the muscle now becomes stiff and hard, it's not stretchable, then things cannot really be contained, just had to come out. Increase, we think of a kind of floppy rectum, really compliant, really stretchable, can be seen in megarectum or irritable bowel constipation. All right, this is kind of the key for some of our motility specialists that when we do the simulated defecation. So over the years, I think there are many names to it. Nowadays, we call it dysynergic defecation. That's probably more descriptive in terms of you essentially have this incoordination of muscle and they're not synergistic, and then it's resulting in issue with defecation. Over the years, it's the same name. People call it anesthetics, people call it pelvic floor dyssynergia, pubic rectalis dyskinesia, non-relaxing pubic rectalis syndrome, functional defecation disorder, but I think dyssynergic defecation is what we're going to go with. There are actually 4 types. I don't have to go into it. Essentially, think of it. You need to have a propulsive force in the rectum, so increased pressure in the rectum, and you need the anal sphincter muscle to relax in order to push things out. Simple, right? So if any of that mechanism is not working, so the most classic one, you have a paradoxical, so you're pushing out, but your anal sphincter is closed, well, nothing's gonna come out, and patients gonna suffer and complain and have issue. And that those patients often actually are refractory to medication in their chronic constipation. You can actually, I usually have, you can whip the colon with the small intestine all you want. The stool can even be liquid. They're gonna have little squirts of stool coming out. They still have issues letting things out. And then other ones are essentially you don't have propulsive force, or your anal sphincter just not relaxed adequately. Sensation study. This is where when we descend the rectum, descend the balloon in the rectum, and then we ask when's their first sensation. Well, when do they feel the urge to defecate, and what's their maximum tolerated volume? So we go from 10 milliliter to 20 to 60 to 90 to 100 milliliter. Now, patients who have rectal hypersensitivity, they have these increased perceptions. So even when the balloon is in a very small volume, they say, oh, I'm feeling pain already. And usually you can see that associated with urge incontinence, proctitis, irritable bowel syndrome. Decreased perception, so you can descend the rectum 120 milliliter. So most people, we should actually have an urge sensation about 60 milliliter. So those patients, 120 milliliter, they say, I don't feel the urge to go. Well, you know what's going to happen with those patients. Your rectum going to be so full, but you don't feel the need to go. And then all of a sudden you feel the urge. I can only have 5 seconds to get to the bathroom. That's what those patients will complain with. So they're associated with incontinence, megarectum. These can be improved with biofeedback. Essentially, it's through sensory training to teach them to really be sensitive to when they feel that urge. Balloon expulsion test, this, Dr. Che yesterday talked about this kind of a device you can do in clinic. Essentially, you put about 50 ml balloon into the rectum and have patients sit on the commode and then have them say, hey, go ahead and defecate out the balloon. If they don't defecate within 60 seconds, there's some kind of defecation disorder. So it's a very easy test to do. And we do that in conjunction with our anorectal manometry. So constipation, just right, it's such a word. There's so many overlapping subtypes. There's IBS-related slow transit due to myopathy, neuropathy, dyssynergic defecation. But we always want to make sure when we talk to a patient is to separate out, well, not necessarily, but really try to find out, do they have additional issue that's more due to evacuation disorder? Or do they, such as dyssynergic defecation, or do they have actually structure issue that's inhibiting the ability to defecate, such as rectal prolapse, rectal seal, or even rectal intussusception? So when do we use anorectal manometry in a constipation evaluation? Here, I want to emphasize history is so key. I can't tell you how many times I have patients come to my clinic, they say, doctor, I have diarrhea. I say, okay, and I go 10 times a day. I say, okay, and then when you probe them more, oh, I go 10 times and my stool had little pellets. But I go 10 times a day, so I have diarrhea. And my doctor gave me Imodium. And this is where you realize if you don't probe the patient more, if you just hear that initial complaint, but if you don't ask them about the frequency, the consistency, of the stool, with even the volume of stool, you might actually treat the wrong way. So it's very, very important. Sometimes patient may have diarrhea due to overflow incontinence or overflow constipation. So I can't emphasize how much we really need to ask them about these questions. So after a good interview and physical exam, you want to consider metabolic and structural evaluation, baseline labs, thyroid, CBC, all that. And then actually start them on therapeutics. You can give them trial fibers, and there's over-the-counter laxative. There's a lot of prescription medication for chronic constipation. We really have a lot of options there. Now, if they don't have adequate response, this is time you say, okay, well, let's do anorectal manometry and expulsion test to make sure that there's not a defecation disorder. This is more anorectal as opposed to maybe just a small bowel or a large bowel problem. We also use this in fecal incontinence, and the cause of fecal incontinence can be quite varied. Most people, actually, I think patient conception is, oh, I have a weakness in the anal sphincter, which it's true. You can have it either from trauma, I think obstetric, surgical, accidental, or non-traumatic, such as scleroderma, internal anal sphincter degeneration, which some kind of neuropathy that affect your pudendal nerve, and commonly we can see some of that in diabetes. That also actually may affect the sensation, as I mentioned earlier, right? They don't feel that rectal urge distension until 120 milliliter later. Pelvic floor disturbances such as rectal prolapse, inflammatory conditions, so radiation proctitis, inflammatory bowel disease, or central nervous system disorder, dementia, stroke, whatnot, and then IBS related. The other, actually, probably I see more common than that is actually the fecal retention or overflow. Again, going back to patient really actually are chronic constipated, and they just have actually overflow incontinence and overflow diarrhea. Behavioral disorder we do see, but much more rare. Anorectal manometry evaluation in fecal incontinence is really looking at sphincter dysfunction, and then also to assess, do they have any impaired rectal sensation? Sphincter defect can be seen generally in first delivery, where those delivery assisted with forceps, those are highest risk. It's also associated with the anorectal surgery, again, going down to hemorrhoidectomy. Let's not remove those hemorrhoids too quickly, people. Okay, we need that for continence. People with surgery for anal fissure or perianal fistula or accidental injury. So when you put these patient fecal incontinence through anorectal manometry, about 74% you can find with one or more sphincter dysfunction. And here is the number about isolated just internal anal sphincter dysfunction, about 30%, those with both about 33%, and those just isolated external anal sphincter dysfunction, about 11%, and those who are normal, about 26%. All right, I'm gonna switch gear a little bit. So you diagnose them with, let's say, dyssynergification or fecal incontinence. What do you do with them? You know the laxative probably not gonna be effective. So the way is treat them is biofeedback. So what is biofeedback? The biofeedback is a therapy where people are trained to improve their health by using signal from their own body. It is a behavioral approach to correct inappropriate contraction of the pelvic floor muscle and external anal sphincter during defecation. You get that visual information input about the physiological process, and patient gets feedback and then can adjust behavior. So this is not used just in fecal incontinence, in constipation. It's used in actually anxiety, depression, people after stroke. So when you assign patients to biofeedback, make sure you be specific. I had patients say who had experienced biofeedback, and I said, "Oh, you're gonna need biofeedback therapy," and the patient saying, "No, I have no depression right now. I'm fine now." I said, "No, this is biofeedback for your anal sphincter, not for this other purposes." So again, specificity. So, we do this so often. Sometimes we forget to tell patients that. Okay. Next. Okay. The indication of biofeedback, and so on the left is an indication, on the right is a strength of evidence. I think the best strength of evidence is really for those who have used for long-term, short-term treatment, constipation with dyssynergic defecation. Okay, so if you have a patient with chronic constipation, they never even tried on fiber or other things, I wouldn't just throw them to biofeedback. I would actually try the kind of over-the-counter therapeutic, and then to show that they have dyssynergic defecation either through anorectal manometry or office balloon expulsion test before you send them to biofeedback. Those who have needing treatment for fecal incontinence, a little bit less, the strength a little weaker. And then those with levator ani syndrome with dyssynergic defecation, with those with solitary ulcer syndrome of the rectum with dyssynergic defecation. So ultimately you want to show that they have that dyssynergia. That's when the biofeedback will be helpful for them. Biofeedback for chronic constipation, those with dyssynergic defecation, is actually more effective than laxative. And going back again, right, we're talking about these coordination of muscle. You just give them a laxative, it's not going to help them coordinate those muscles. So really benefit with patient dyssynergic defecation, not slow transit constipation alone. A biofeedback for fecal incontinence is really have patient to strengthen the muscle, to sensory training, coordination training, so then they can increase a voluntary squeeze response to rectal distension. That's very important. It is not indicated. So if they only have internal anal sphincter muscle weakness, because again, we only control the external sphincter muscle volitionally. Internal, if you have issue, we can't control it, so you can't really train that. Or they have overflow incontinence associated with behavioral or psychiatric disorder, or neurological disorder associated with substantial loss of rectal sensation or inability to contract external anal sphincter, would really decrease kind of the compliance, so they don't have that storage capacity due to inflammation, resection, fibrosis. And I have seen patients like that. They come to my clinic, they have bad radiation proctitis, the rectum is so woody, there's really no pliability, and biofeedback is not going to help with that. Suspected established major structural damage to incontinence mechanism. So for some of these patients with fecal incontinence, when they come to my clinic, I will also do an endoscopic ultrasound where you can do an MRI to look at the anal sphincter structure, make sure there's no huge defect. If you have like a 180-degree circumferential kind of defect, I don't think you can train the muscle and help with the continence. The challenge, of course, is limited data and the method of how these are tested. And that's why there's a wide range of success rate between 38% to 100%. So you have to let patients be aware of that. Biofeedback modality, and that's another thing. There's different ways to do biofeedback. In our center, we use anorectal manometry. I think UCS said last time when I talked to Susan Wong, I think she has since retired, is actually they're using EMG. Some center we even send patient home with a device which they can train at home. Randomized control trial usually show biofeedback is superior to Kegel. I think some women just instinctively say, oh, I have incontinence leakage here in the urine, leakage in the anus, I'm gonna just do Kegel at home. That's generally not adequate. There's no significant difference between a sustained squeeze maneuver versus combination of rapid and sustained squeeze maneuver. So I tell patient, as I go to the gym with a trainer, different trainer have different method, and some patients are more receptive to one way of training versus another. So for my patient who may have failed at my center, I would send them to UCSF, say, hey, maybe try this kind of way of training biofeedback, and maybe you get better results. Ultimately, we just want patient to get result and feel better. And there hasn't been really a way, say, certain biofeedback is more superior than the other. So it could be equally effective. All right, I'm gonna switch gear altogether. So I was asked to speak on high resolution endoscopy. I think this is an important thing. I feel like as GI, we don't know enough about it. I do not do high resolution endoscopy, just to make it clear out there, but I have learned that we have a primary care doctor in my center. His name is Lou Cuba. He has an interest in patient with anal dysplasia, and he has twice a week do this in his clinic. And what high resolution endoscopy is, an examination of the anal canal and perianus using colposcopy and with the application of the 5% acetic acid and lugoiodine solution. What you're looking for really is to get pathology assessment. So you're looking for a high grade squamous intraepithelial lesion or invasive anal cancer. This is really to use to screen or prevent anal cancer. So who should get high resolution endoscopy? And the rationale really screening for anal cancer, we don't really have any randomized clinical trial for that. And the rationale to do this is really the similarity between anus and cervix. And there has been really a good success in looking at cervical cytology and reducing incidence of cancer. So we're not screening everybody. We're really going to focus on the population that has increased risk for anal cancer. So those are people living with HIV, men have sex with men, immunosuppression, so people who have solid organ transplant recipient, long-term oral corticosteroid, women with history of cervical, valvular, or vaginal squamous intraepithelial lesion or cancer, and women with history of HPV infection, or individual with history of anal genital warts. Those are the patients you want to screen. Now, the timing, the frequency of screening is also very challenging because there's no consensus. There's no randomized control trial, right? So a lot of these are based on experts' opinion. So they found that there's very little cancer in patients who are younger in the immunosuppressed, and then patients who are less than 40 in the immunocompetent. So one of the suggestions is, if you're immunosuppressed, once you hit age 25 and above, we should actually think about start screening. If you're immunocompetent and are in this risk category, then maybe after age 40. If you have HIV, it's annually, and an at-risk HIV negative patient, you should probably do it every 2 to 3 years. So generally, you start with a cytology, and then after cytology, you can kind of distinguish are they low grade, high grade, and then to if they're abnormal. Essentially, it's normal cancer. If they're abnormal, you should get a high resolution endoscopy. And here's an important note on high resolution endoscopy. It is not appropriate to offer screening to at-risk population if you don't have a local expertise in interpretation of the screening results, and you don't have a referral infrastructure for HRA with biopsy, as well as access to ablative treatment and follow-up. So it's important that you kind of know your local expert and what kind of support you may have. So just a quick kind of overview of how this is done. You start with patient coming in, you pull a regular anoscope, you insert a Q-tip wrapped in the gauze, soak in the acetic acid through the anoscope. You let it sit for 1 to 2 minutes, kind of the middle picture, and then to the all the way to the right is where you start using the colposcopy. And what you try to do is really identify the squamous-columnar junction. I guess it's not too different from if you think of for GI, right? We think of Barrett's and the esophagus and the stomach, and then looking for any kind of changes there. You do Lugo iodine after identifying all the aspects of the anal transition zone. Usually normal squamous epithelium should stain about mahogany brown, and then any dysplastic kind of tissue would be yellowish. So here's some characteristic finding on a high resolution endoscopy exam. Squamous metaplasia, you actually see kind of starting to see this whitish stain. So early one, the first picture, you can see where the yellow arrows pointed to, and then the late metaplasia is starting to become more white. On the high-grade dysplasia, you can see actually punctation, and this is in the middle picture. And then sometimes you may even see mosaic pattern, which is the one all the way to the right. So treatment of these dysplasia. So what you want to do is really, this is actually an amazing study that came out at UCSF called the Anchor study. They have about over 4,000 patients, and they actually was found through the study that removing high-grade squamous intraepithelial lesions significantly reduced chance of anal cancer. So this is part of very, very few studies that actually show that there's a use for this. So the way you can treat it, you can use trichloroacetic acetic acid, you can use infrared coagulation, you can use radiofrequency ablation, or use electrocautery. And the picture on the left and the right are some of these instruments, and then the middle picture are just showing you the high-grade dysplasia area, the white area, and they use the Lugo stain, and then they treat it with an IRC integrated. Now, if we talk about treatment, we cannot emphasize enough about prevention. And I know we think, oh, okay, we're GI, or we're talking GI patient, we're not PCP, we're not pediatrician, but you know what? To our kids, to our friends' kids, to our patients, family, I say we gotta preach it, right? Prevention is key. United States immunization practices really recommend immunization with HPV vaccine. So all male and female at age 11 to 12 years old, before they become sexually active, we really want to kind of prevent that before they become infected. And vaccination can actually start as early as age 9 and continue throughout age 26. This recommendation actually extends to all immunocompromised individuals, including people living with HIV. The US FDA actually approved the use of this HPV vaccine for adults 27 through 45 years old. So as we may encounter this patient, we should just preach it. Prevention is key. Okay, so here's my summary. Anorectal manometry, very useful to assess anorectal function in patients with chronic constipation, fecal incontinence, pre-post surgery, and be used in biofeedback. Biofeedback therapy is a treatment option in chronic constipation with dyssynergic defecation and fecal incontinence. The availability, the efficacy though may vary, so depending on your local area of expertise. The high-resolution anoscopy is a useful method to screen and prevent anal cancer in at-risk population, but should only be offered with available local expertise in the interpretation of the screening result and those who can have access to ablative treatment and follow-up. Okay, so I will stop here. Any questions? Thank you for your attention.
You said that biofeedback that Kegels are inferior to biofeedback.
Not fecal inferior. Fecal is not as helpful. So if you think of Kegel, most people are doing it more for urinary incontinence, and that's when the pelvic muscle. If you have more isolated anal sphincter muscle issue, you squeezing your